Water. Good evening to everyone and welcome to today's session. Uh, Padmanabha, Rituraj, Sweta, and many more who are all online. We have a new format of the broadcast. Uh, this is you apply a green screen in the background and everything else disappears, and you can be more interactive. The teacher can be more interactive with the students. So please give me a feedback how you felt about this new format of the broadcast. We have Biju, Chandrakant, Hema Chowdhury, Ranjit, Rituraj, and many more who are all online. So today, let us start with the quiz first because the PowerPoint of biochemistry is getting ready, right? So, shall we start the quiz? Excellent. In this new format, the advantage is you get the complete opportunity to view the PPT, and that's a great advantage. So let us see. Ritu is asking, do we have the whiteboard or not? क्यों नहीं? I have this pen, and we have got a electronic marker which is a whiteboard. So you can give me a feedback on that also, right? So let's make the great beginning, doctor. Yeah. A patient presents to the emergency with hypertension and ECG was recorded. What is the immediate management? So what is your answer? I can be able to see Ritu proposing DC cardioversion. DC cardioversion? Yes. So this is the typical ECG. So what is very important is you have the broad complex QRS, which is a very important feature about these waves. So, what is your answer? That's good. I can be able to see DC cardioversion, especially with when there is hypotension. Hypotension is a key feature here. So that makes DC cardioversion as the answer. Very good. A 20-year-old female, 20-year-old female comes with the complaints of headache, vomiting, and decreased movement of the right leg. She had an episode of violent and aggressive behavior, and her urine sample is being shown to you. Urine sample. So, what is the most possible diagnosis in this given case? So, what is your answer, doc? Shoot your answer. Good to see 26 online students. The main advantage is I'm able to sit in the home and be able to deliver. I have set up a small facility in the home itself. So even if I am in Andaman Nicobar also, I can be able to deliver a class, a live class. That is an advantage of this format. But you should tell me whether you're all happy with this new format or not. Yes. What's your answer, doctor? Roshan, Madhu are differing between A and D. Madhu is thinking acute myoglobinuria. I know that is the most possible wrong answer. The reason is this color is the one which is making you to, yeah. Oh, I think I could not be able to. Yeah, this is the color, right? You can appreciate the color here. Yes. Considering the overall history of the patient, the answer would be the acute intermittent porphyria, right? Huh. So the urinary ELA and the PBG, they are the ones which are markedly increased whenever the patient is having acute intermittent porphyria, even if the patient is asymptomatic, there is a rise of them. And this port wine reddish urine is a very important clue. Port wine reddish urine is an important clue to say that on standing, it is a case of acute intermittent porphyria. A patient with fever is admitted. His chest radiograph has been shown to you. Now, looking at this chest radiograph, you must be quite sure what is the diagnosis. In chest radiograph, what are the possible diagnoses, doctor? Either effusion, hemothorax, pneumothorax, pneumonia. These are the 5 to 6 things that you should be in a position to recognize on a chest radiograph. Now, the question is, if you look at the prognostic score of this patient, Deepika says, sir, we are happy that you are able to sit and teach. Actually, sitting and teaching is a more bigger punishment because standing and moving around will prevent deep vein thrombosis, right? So, Deepika, but thank you very much. You care so much and feel so much that the teacher should sit. Good. So now I am in a air-conditioned room in the home. You're also sitting in the home. Now we are both are equal, right? That's an advantage of this format. So Rituraj is proposing D. Shweta says D. Very good. And good. Akhileshwar, welcome. Good to see 32 online students. So, doc, you should remember that there is something called Karb score. You need to know. So, Karb mein kya hota hai? This is one of the favorite question. So, Karb mein hota hai C for confusion, U for urea, R for respiratory rate more than 30, and the B is systolic blood pressure less than 90 or diastolic blood pressure less than 60. And the age is very important. So age more than 65 is also considered to be one of the important addition to the Karb 65 score for the pneumonia severity and prognostication is what you need to remember. Now, you are being shown a baby, right? ठीक तरफ देख लेना. Now, all the clinical features are seen in the mother who had infection while pregnant with this baby. After looking at the baby, you must have got what is the infection the mother had at the time of pregnancy that led to this dysmorphism in the baby who is being born. So now, doc, shoot your answer. What are the important clinical features? Except, yeah, question number 14. हाँ, फटाफट बोलना, आपका आंसर क्या है? Now, one advantage I am looking, if this goes well, you should all say that this is a good, this format is okay, the voice is okay, the broadcast quality is also okay. If you all say okay for that, then we will continue like this. One advantage of this is a Early morning 6 o'clock also. I need not travel all the way to studio and classroom and then deliver. Morning 6 o'clock also, 6 to 8 we can have a session. And evening, whenever we can plan at any time. That's an advantage of this session. Especially October, November, December jab aata hai, all students are vibrant to have interaction, to reignite themselves. So that is the time. More in a single day we can have 2-3 sessions also. That's a great advantage if I happen to deliver the presentation directly sitting in the home. So you need to give me a feedback at the end of the session, how you felt about it. Good to see 41 online students, very good. Call your friends. Today teacher is from home, you are also from home. So doc, you should remember it is a Zika fever. So Roshan Yadav, Ranjit Shah, Argha Saha, most of you are correct. Gulenbari nahi hota, petechial rash, fever with arthralgia, etc. will be there. Now, you are being shown the guide in a polio patient. In the polio patient. Why is this guide is adopted? It is because of which muscle weakness the person need to go into this kind of a guide is a very important question. Good to see 44 online. Yeah. Is the voice loud and clear for everybody? Hope there is no resound or quality of the sound. If it is okay, the quality of the sound, I don't need to wear a mic. That's an advantage. Yeah. So, very good. Ritu Raj proposes quadriceps. No, doctor. It is the involvement of the hamstrings, which typically lead to this guide is what you have to be very sure about. Right? Satya Snigdha Tripathi says quadriceps, but hand to knee guide is mainly due to the involvement of hamstrings is what you need to remember. Now, which is the test which you will do to diagnose this condition? You should know what is this condition and tell me what is the test you want to use. Yes. Shoot your answer, doctor. So, which is the test you want to use in order to diagnose this condition? Yeah. So, is it IGF-1, ACTH, Mala Krishna, Arga Saga, and Radhika Pillai? Very good. Radhika, you are from which part of the country, beta? Are you from Trivandrum, Calicut, Cochin? From which part is Madam Radhika Pillai? Good. Yes. Dragon Dreams is proposing IGF-1. Dragon Dreams Jindabad. That's good. So you should remember it is acromegaly, and that's the reason IGF-1. Now you're being shown a diffusion weighted MRI. Diffusion weighted MRI. So the window period for the thrombolysis in the patients whose diffusion weighted MRI is being shown in the figure. You are the casualty postgraduate on duty in casualty, patient arrived and diffusion weighted MRI done. So what is the window period for thrombolysis? Is a simple straightforward question. Yes, doc. So Manoj Singh, Brahmatirtha Chaturvedi, Ranjit Singh, they are all differing between C and D. Yeah, C and D. Yeah, please shoot your answer, doctor. Sailesh Kumar is proposing B. Madhu is proposing B. Yeah. So it is 4.5 hours. You have to be very precise on these values, doctor. Satya Snigdha Tripathi Jindabad. So also Dragon Dreams, who gave the correct answer. Very good, very good. Now, doc, 2 days after the surgery, this is the pre-operative. The first one is this is the pre-operative and this is the post-operative. Looking at both of them, right? You got an idea? Now, 2 days after the surgery, where pre and post pictures are given, the patient develops sudden onset of shortness of breath and a low-grade fever. What is the most likely cause? Is a very important question. Question number 18. Good to see 60 online students. Very good, very good. So please do call your other classmates and yes. Dragon Dreams, Arga Saha, and Immediate Corpse. Oh my God, ye kya naam hai bhai? And Madhu is proposing fat embolism. Absolutely right. Now, it is a case of fat embolism. Now, a 27-year-old lady, look at the histology, right? A 27-year-old lady and 20 weeks of pregnancy. 20 weeks of pregnancy. Presented with a thyroid nodule on the right side. And this is the histology. Which of the following is contraindicated in the management of in her management? Yes. Good to see Commandant. Yes. Manoj, Ranjit Shah, Vishalakshi. Everyone is proposing C. Very good, very good, very good. So, absolutely, radioactive iodine ablation is contraindicated. FNAC is showing the orphan Annie-ide cells, which are the classical feature, which you see, the orphan Annie-ide cells are the ones which are classical feature in case of papillary carcinoma. And that is the reason the radioactive ablation is contraindicated, but right lobectomy, total thyroidectomy plus neck node dissection and total thyroidectomy, they're all indicated. Now, the following is a thyroid scan. Pehla thyroid scan ko dekho. Now, the most probable diagnosis of this thyroid scan, what is the most probable diagnosis of the thyroid scan? Yes. Very good. Commandant all the way reporting from the casualty of Armed Forces Medical College. Good to see, Commandant. So, Alka Ravi is proposing B. Lateral aberrant thyroid. Satya thought it as C. Okay. So, C is correct. Satya is correct. That, yes. It is hypersecreting adenoma is what you should remember. Now, a young lady, this is the young lady, okay, now, a young lady presented with midline neck swelling and it moves with deglutition, swallowing. It is stable in size for last 1 year. What is the most likely diagnosis? Question number 21. Yes. Should you answer, doctor? Deepika is proposing C. And Shweta proposes A. And Vishalakshi thinks it is thyroglossal cyst. Vishalakshi Jindabad. Very good. It is thyroglossal cyst. A 22-year-old female presented with a history of painless breast lump. Painless breast lump in the left upper quadrant. She undergoes surgery, resection of all tumor tissue, and the HP is being shown, histopathology, and there is a 4 millimeter clearance of the margins. Now you got all the clues. This is the typical histology. You are able to see necrotic cells, right? Necrotic cells over here. So what is the treatment that you want to offer for this given scenario? Oh, sorry. Is it adjuvant chemotherapy, adjuvant chemoradiotherapy, only adjuvant radiotherapy, or no additional treatment? What is the treatment that you want to offer? Good. Actually, answer is shown up. So, it is a high-grade ductal carcinoma in situ. High-grade ductal carcinoma in situ with a central comedo type of necrosis. Yahan adjuvant radiotherapy is the one which is being preferred in view of the 4 millimeters of clearance that it is showing, 4 mm clearance that it is showing. Now, doctor, a 56-year-old patient comes to casualty with a history of massive hemoptysis. His chest X-ray is being shown to you. दिल लगा के देखो कुछ दिखता है क्या? कुछ दिख रहा है क्या? हाँ. So, his chest X-ray is shown. Which of the following maneuvers is not done to prevent hemoptysis in this given case? Yes. What is your answer, doctor? In this given case, where the chest radiograph has been shown to you, yeah. I'll show you the radiograph once more. Have a clear look. What's your comment on the radiograph? So, which is not done? That means remaining are all done. So, what is your answer? Radhika Pillai is proposing B. And Akash Yadav says B. Manoj Sinde says C. Alok Singh B. Dragon Dream say B. Very good. But Rituraj, Roshan Yadav, they are proposing lobectomy, right? See, doctor, what you are seeing here, this is a normal X-ray, doctor, normal radiograph. Normal radiograph जब रहता फिर भी hemoptysis है समझो. Then where is the pathology? Pathology is not there in the lung parenchyma. Pathology is inside the bronchi for the source of hemoptysis. There's a reason always when hemoptysis is there, get a radiograph. If there is any abnormality seen on the, or like a mass lesion is seen in the parenchyma, then you need to do lobectomy, etc., etc. But if there is no lesion seen, radiograph is normal, as in this case, you need to do bronchoscopic laser cauterization or pulmonary artery embolization or the bronchial artery embolization. They are all the various treatment options, is what you need to remember. Now, doctor, in the patient, as shown below, chest X-ray closure has been achieved. What is the flap which is being used for that purpose? So, this flap, which you are able to see, right? So, this is the flap used on the chest. So, the question is, what is the material used to do this closure? What is the flap which is being used? So what is your answer, doctor? Very good to see 72. Aaj 100 aana chahiye, right? So on Sunday, I told you I was going for second show movie, Super 30. I was having tears watching Super 30 because in 1999, when I started coaching, I was myself preparing for PG medical entrance. There used to be a small school, about 150 students from Usmania, Gandhi, Deccan Medical College. Already I was a popular writer of MCQ books in MBBS days. So they were all sitting in the class. I myself, they know that, was preparing for entrance exam, right? So early morning, 4 o'clock, I used to come and draw all the illustrations on the whiteboard. And I never, even those days or any day, money is a byproduct. So my students, somebody used to pay 100 rupees, another 500 rupees, another 1000 rupees. Maximum was 1000 rupees fee. So that batch, in the 100 ranks, 84 ranks came to all our students in 1999. So I still remember by face each of those students who spent 6 months with me and made me to become a successful teacher. So let me really, while watching the Super 30 movie, I was having uncontrollable tears. So I should thank all you students that because of you, every day evening is an eventful time for me to spend with all of you. So thanks for coming to the session, and let's hope that till January, until the NEET exam, we'll all be able to journey together to get inspired every day to finish as much as the high yield topics which are frequently tested, we try to cover up, right? So, Doc, you should remember it is pectoralis major myocutaneous flap, which is being used. Now, Doc, a 1.5-year-old child. Thank you, Deepika, that always to prepare for a class or to prepare new MCQs, image-based questions, or to prepare a mock test paper. Always I remember you, and I remember myself as a aspirant of exam and prepare the question paper, right? So a 1.5-year-old child was brought. This is the typical lesion. Have a look at it. Now, there's a history of burn by the hot water on both the hands and palms. Lesion is shown. What is the best management of this case? Question number 25. Should your answer, Doc? Alok Singh is proposing apply 1% silver sulfasalazine ointment. Manoj Shinde is also agreeing with that. What are your other chances? Satya proposes paraffin gauze and dressing. Absolutely right. Paraffin gauze and dressing. The lesion was pink, oozing, painful to air and touch. Now, Doc, a young boy presented to the casualty with a history of fever. Good to see you, Monica, once more today evening. Yes. There's a history of fever, pain, abdomen, vomiting. On examination, he was febrile. Pulse rate was 104 per minute. And the resident was eliciting, let us say commandant is eliciting this in Armed Forces Medical College casualty. So what is that commandant is trying to elicit in this? Should your answer? Yes. Manoj Sinde, Malakrishna, Radhika Pillai, all of you are proposing C. McBurney's tenderness. Absolutely right, Doc. A patient underwent laparoscopic cholecystectomy and was discharged on the same day. On post-operative day 3, he presented to the hospital with fever. We have done a ultrasound. So this is the gallbladder, right? This is the gallbladder. And yeah, good. Now, this is the gallbladder. And looking at this gallbladder, uh, ultrasound, what is your next line of treatment is a very important question. Very good. We have 80 online students. Call your friends. We are going to have 2-3 sessions in November, December, May. 2-3 interactive sessions across the day to be constantly with you, right? I will not let you to stop reading. That's a goal. Now, doc, um, yes, Hiren is proposing C, and Russian P is proposing B. Alok Singh also says B. Yeah. What is your answer, doctor? It is the pigtail insertion and the drainage, which is the one which is a preferred treatment. Right? The ultrasound was showing the collection with fine internal echoes in the gallbladder. Now, a middle-aged old female presented with recurrent bloody diarrhea. Okay? Colonoscopy reveals multiple geographic ulcers, and histopathology is being shown to you. Colonic histopathology. So, in the histopathology, one of the important things is you are able to see a lot of inflammatory cells getting accumulated, right? So now, what is your diagnosis? Question number 28. Animation is proposing D, Madhu D, Shweta A. Shweta is proposing A. Alok says B. Very good. So, and Ritu says Crohn's. Excellent. It is a granuloma in the mucosa, which is a classical feature of the Crohn's disease. Now, you are being shown the histology and the imaging. Right? Histology and the imaging. Looking at this histology and imaging, what is the question is maximum risk for this condition is seen in which condition? You are able to see the histology, right? Histology. So what is your answer, doc? Where do you see the maximum risk for this condition? Should your answer, doc? Yes. Question number 29. A. Manoj is proposing C, Pute Jaga. And Radhika also says Pute Jaga. Absolutely. It is a histology of the carcinoma pancreas. Carcinoma pancreas. So, the maximum risk for that is with Pute Jaga. Now, 55-year-old patient presented with dysphagia, and this biopsy has been taken. Biopsy has been taken and identify the diagnosis. This is taken from the upper GI of biopsy of esophagus. It is being shown to you, right? So, looking at this histology, you should pitch on a potential diagnosis. Question number 30. Mention the question number, doc. Yes. Satya Snigdha Tripathi is proposing C, and uh, Vishalakshi is proposing C. Very good. Vanishri C. Shweta says C. Very good. So you should remember it is Barrett's esophagus. Barrett's esophagus is what you are able to see. Now, chest radiograph was missing. Okay. Let's take the question number 32. A middle-aged male presents with fever and diarrhea for 1 week. A middle-aged male with fever and diarrhea for 1 week. And there is a acute onset of pain. Very important clue. And a erect abdominal X-ray has been taken. You are able to see the typical border. Yeah, this is a very important clue. You are able to see the border. Yeah. So what is your diagnosis? In this middle-aged male patient presenting with fever and diarrhea. Yeah. Shoot your answer. Question number 32. Shweta and Vishalakshi, everyone is saying C. Anvesh is proposing D. Acha. Anbeshan. Okay. Very good. Ranjit is saying that मुझे एक dilated large intestine दिख रहा है. बढ़िया. So, is it A or D? It is typically D. The toxic megacolon is what you should remember. So that completes the quiz, doctor, and the image-based question quiz. So every day, if we are practicing about 20 questions in image-based question ka quiz, we will become the champions. I could not get the biochemistry PowerPoint. Our guys are still arranging the PPT. Before we get the biochemistry PowerPoint, let us take a quick continuation of our discussion of NEET PG 2019 का क्वेश्चन पेपर हम शुरू किया. बीच में MDS बायोकेमिस्ट्री वालों का क्वेश्चन बैंक शुरू किया. Because of that, we could not complete some questions. We will continue for a while the NEET PG 2019 paper का question bank discussion, and meanwhile we'll get the biochemistry PPT. Let's make the start. The graft from mother to son is what is the, keep punching your answers. What is the type of graft is it called as? It is called as an allograft. So you should remember that you have a autograft from one part of the body to the another. You call it as autograft. These are all NEET PG 2019 pattern question paper. Isograft is between genetically identical individuals. Allograft is between different members of the same species, and xenograft is between the different species. That is what you need to appreciate. What is the inheritance pattern of achondroplasia? Achondroplasia is a structural protein disorder. That's the reason it is an autosomal dominant pattern of inheritance. So you should remember that there are certain things when you look at the pedigree you can be able to recognize. Here you are able to see grandpa, daddy, grandson. 3 consecutive generations got affected. That is the typical thing in pedigree you should look for to recognize an autosomal dominant. Males and females, female and male, both of them are affected. That means it is not sex linked, rather it is autosomal. That is what you need to remember. Autosomal dominant inheritance pattern shows incomplete penetrance. Now, what is the wrong statement about Barrett's esophagus? So, Barrett's is a squamous to columnar, not columnar to squamous. Otherwise, the remaining statements are true. That gastroesophageal reflux predisposes. It involves lower esophagus, and it is a predisposing factor for the adenocarcinoma, is what you should remember. And typically it is around 55 years, constant reflux from a long period of time lead to development of the Barrett's esophagus. Where do you see Cushing's ulcer? These are all NEET PG 2019 जनवरी में जो एग्जाम हुआ, so उसके पैटर्न का क्वेश्चंस हैं. So Cushing's ulcer, you should remember that it is typically seen in the case of the head injury. Then partial mole has how many chromosomes? So this is a favorite question of the examiner, doctor, that how do you differentiate partial mole and the complete mole? So once more, these features barabar yaad rakhna, that karyotype, doctor. Partial mole का karyotype है 69, triple X and XXY. हम बहुत बार डिस्कस करें इसके बारे में. Whereas complete mole, it is 46, it is XX or XY. And fetus, it is often present if it is a partial mole, whereas it is absent in case of complete mole. Similarly, amnion, fetal RBCs, they are usually present in case of partial mole. Villus edema is focal but diffuse in case of the complete mole. And trophoblastic proliferation is focal in partial mole, whereas it is diffuse in complete mole. Then, as a missed abortion, that is the way the presentation is for the partial mole. And the uterine size, if you look, small for date babies, that is how the partial mole presents. But complete mole, agar aap dekhe to, 50% of times it is like a large, 50% are large for date babies if it is complete mole. So that is the reason you should emphatically remember two important points here. That is, one of you is asking, sir, board hota ya nahi hota? Kyun nahi hota? Board ke bina we can't enjoy, right? So you should remember that partial mole, whenever we say partial mole, please don't forget that small for date baby. Whereas complete mole, jo hota hai, it is 50% of times large for weight, large for date babies. This is one point which you should not forget, right? Now, thecal lutein cysts, if you take, they are rare in partial mole. This is another important point. Complete mole jo hota hai, 20 to 30% of cases mein you find thecal lutein cysts. Thecal lutein cysts. This is another very important thing. Complete mole, thecal lutein cysts. High HCG level jab hota hai, then thecal lutein cysts are the ones which typically appear. Then medical complications are more often a feature in case of the complete mole. And very important question, doctor. After the molar pregnancy, there is a great risk of developing choriocarcinoma. So what is the risk opportunity, risk possibility in partial versus complete? Partial has only 2.8%, relatively lesser choriocarcinoma changes, whereas complete mole जो होता है, there is a greater chance, that is up to 6.8 to 20% possibility is there for the choriocarcinoma, is what you have to ultimately remember. Now, fish mouth valve appearance, where do you see? We see it whenever there is any calcification, fibrosis, in case of the mitral valve, in the case of the rheumatic fever. So this is the classical fish mouth appearance. Fish का mouth, पहला fish क्या है, fish का mouth क्या है, कैसे दिखता है, मालूम होना है. तो fish mouth appearance in case of the rheumatic fever. Now comes बट्टी मारने वाला question. Which is the gene which is an apoptotic inhibitor? Is a very important question. Apoptotic inhibitor. So, pro-apoptotic, anti-apoptotic. You have to be very sure, doc. So, BCL2, keep punching your answers, doctor. These are all NEET PG 2019 question bank that we are doing the revision. Yes. So, you should remember that what are pro-apoptotic, anti-apoptotic. पक्का बट्टी मारने वाला क्वेश्चन है. Backs, back. BCLX, bad. Bid, big, HRK. These are the pro-apoptotic genes. 100% you should be sure. Whereas BCL2, BCLXL, BCLW, BFLM, and BRAG1, MCL1, very important, A1, इन चीजों को भूलना मत. These are the anti-apoptotic genes. You have to keep pen, paper, 200 pages book. ये स्लाइड आपको मिल जाता, पीपीटी में रहता, बुक में रहता, सारे जगह पे रहता, इधर रहना है, इसलिए हम जरा स्लो जाना है. बट एपोटोसिस, विदाउट दैट देयर इज नो क्वेश्चन पेपर, डॉक्टर. बी 100% श्योर अबाउट इट, राइट? हाँ. नाउ डॉक्टर, वेरी गुड. ऋतुराज सेज it leads to development of follicular lymphoma. Absolutely. So keep punching some extra points that you know, no? The time to vomit them. That is a purpose. When we are all together, milke padhai kar rahe to, whenever we are discussing a question, जो भी आपको आपके मन में points है, good points है, please don't hesitate to be free. ये फेस टू फेस क्लासेस, क्राउडेड क्लासरूम्स जो होता है, इसमें किसी को बात करने का मौका नहीं मिलता, कुछ बोलने का मौका नहीं मिलता. एक्चुअली वी से दे आर ऑल इंटरैक्टिव, बट नो, लाइव ऑनलाइन इज परफेक्टली इंटरैक्टिव. यू कैन बी एबल टू टाइप योर आंसर्स, यू कैन डू एनीथिंग, राइट डॉक्टर? नाउ, मोस्ट डेफिनेटिव थेरेपी फॉर द ITP. What is the most definitive therapy? Splenectomy any given day is the most definitive therapy. Now, doc, we have come to a very important place called what is your treatment strategy for ITP. So, please remember steroids, IV immunoglobulin any day. So, you can give corticosteroids, dapsone, danazole, vinca alkaloids, rituximab, and TPO or agonists. These two are under the trial. So always, whenever there is ITP, once it is a newly diagnosed ITP, beyond 3 months, you call it as a persistent ITP. Right? Persistent ITP. So, when do you call chronic ITP, doc? Beyond 12 months, you call it as chronic ITP. Ultimately, it becomes refractory. So, when do you consider splenectomy? Typically, once it becomes a chronic ITP, refractory to all forms of therapy. So, please don't forget, we use azathioprine, rituximab, corticosteroids, and dapsone, and even acute phase में IV immunoglobulin has got a role. That's what you need to remember. Now, doc, which is the intrinsic cause of hemolysis is a very, very important question. Intrinsic cause मतलब आरबीसी के अंदर ही प्रॉब्लम है. Typically in case of PNH, paroxysmal nocturnal hemoglobinuria. Now comes a very important classification. गर्मा गर्म याद रखना है. Some of you are going to become MD General Medicine like me and not like me. I never had a chance to prepare for DM, right? I never needed to do it. But some of you are going to, बहुत आगे बढ़ने वाले हैं आप. So DM hematology, wonderful branch, right? So now let us talk about the hemolytic anemias. Hemolytic anemias, whenever RBC is broken, it can be a problem intrinsic to RBC or it can be extrinsic to the RBC. जब वो intrinsic होता है, it can be problem in any membrane abnormality, it can be a enzyme deficiency, or it can be a disorder of hemoglobin. Anything can be responsible. Now, what are the various membrane abnormalities? इसके बारे में चर्चा करेंगे. Yeah. So, what are the various membrane abnormalities? मैं थोड़ा slow जा रहा हूँ क्योंकि PowerPoint फटाफट खत्म होता मगर इधर बैठना है concept. So, spherocytosis, elliptocytosis, they're all membrane defects, intrinsic to membrane. Similarly, membrane lipids में कुछ problem हो गया तो a beta lipoproteinemia, right? Is there anybody who is facing audio video delayed? Yeah, please let me know. We will restart the broadcast. Simple. If everyone is facing, you should not, but still, we don't know about internet. Right? So, spherocytosis, elliptocytosis, and A beta lipoproteinemia. They're all membrane defects which are intrinsic to the RBC. Now, certain enzyme deficiencies which you should remember. What are all the enzymes that can lead to hemolysis, doc? Recently we discussed pyruvate kinase, right? Then hexokinase is another important enzyme. Because RBC doesn't have mitochondria, they are completely dependent on glycolysis. Then G6PD deficiency, whenever there is any oxidant injury, for antioxidant action you require NADPH, which comes through the pentose phosphate pathway, right? Good. Now, what are the acquired? Now, this is an important part. What is that acquired intrinsic cause that is sitting within the RBC responsible for hemolysis? It is PNH. ये जो spherocytosis, elliptocytosis, A beta lipoproteinemia, pyruvate kinase और hexokinase और J6PD, ये सब चीजें जो होता है वो acquired नहीं है, but paroxysmal nocturnal hemoglobinuria जो होता है, that is acquired stem cell defect. Stem cell के level पे defect होता है PNH में, is what you have to fundamentally understand. Now let us talk about what is the exact problem in PNH. So you have the RBC. The RBC, once it is released into plasma, there is a complement which is waiting and trying to attack it. On the RBC membrane, you have something called delay accelerating factor. it will lead to a membrane protein that will prevent the complement mediated lysis. So a PNH जो होता है, it is a manufacturing defect. So when the RBC is getting created in the bone marrow, the time the decay accelerating factor के वजह deficiency के वजह से, the gene of decay accelerating factor deficiency की वजह से, it will miss that protein on the RBC membrane, which is preventing the complement mediated lysis. So such a RBC which is completely naked get released, complement will jump on it and it will destroy it. So that is the basis of PNH. Why PNH is called paroxysmal, not continuous? That too only nocturnal and hemoglobinuria. Hemoglobinuria is one important question. So you should remember that in the night we all sleep. When we sleep, our respiratory rate will come down. When the respiratory rate comes down, what will happen? Carbon dioxide accumulate. Carbon dioxide converts into H plus ions, carbonic acid, and that lead to development of acidosis. And for the complement mediated lysis to happen, RBC को break करने के लिए, you require a low pH milieu. So in the night time, this respiratory acidosis will provide that required pH for the complement mediated lysis. That is the reason typically this is nocturnal. Only night time a hemolysis होता है. And what type of hemolysis this is? It is happening inside the vessel, intravascular. It is not happening in the spleen. If it happens in the spleen, you call it as what? Extravascular. So because this is intravascular, the broken down RBC releases hemoglobin, and that hemoglobin will pass through the kidney into the urine and lead to hemoglobinuria is what you need to remember. इसलिए अभी आपके समझ में आ गए why PNH is paroxysmal, nocturnal, and there is hemoglobinuria because it is intravascular is what you should remember. Then what are the various extrinsic causes? Antibody mediated, there can be transfusion reaction, erythroblastosis fetalis, autoantibodies like in SLE, or there can be mechanical trauma of the RBC, like if what is the best example of mechanical trauma, doc? So there is an entity called microangiopathic hemolytic anemia. इसमें क्या होता है? Typically in the blood vessel, if you look at the blood vessel, in the blood vessel there is a clot rich in platelets. What is this condition called? Hemolytic uremic syndrome, thrombotic thrombocytopenic purpura in सब चीजों में there is a platelet rich, it doesn't have clotting factors, only platelets. Platelet rich clot is formed. When the RBC is trying to squeeze through that, it becomes broken down. And that lead to hemolysis, which is called microangiopathic hemolytic anemia. So microangiopathic hemolytic anemias like TTP, DIC, disseminate intravascular coagulation, or any valve can lead to mechanical trauma. Similarly, malaria is another cause for the extrinsic abnormality leading to hemolytic anemia. So this is what you have to emphatically remember for the tomorrow's exam. Now, doctor, what are the triad of features you will not forget when it comes to the PNH, one of the favorite questions of the examiner? There is a hemolytic anemia. There is a bone marrow failure. Very important. PNH patients will end up in pancytopenia. pancytopenia. Always in case of PNH, initially patient presents with hemolysis. Because of that, he develops anemia. But WBC and platelet count is normal. But one of the CBP you found, it is not only anemia, he's also having a low platelet and also a low neutrophil count. So what complication this PNH patient entered into? He entered into bone marrow failure, aplastic anemia, pancytopenia. Then PNH patients are vulnerable to develop thromboembolism, thrombotic episodes. This is another favorite question of the examiner. So fundamentally, where is the problem in PNH, Dr. Fatafat Bolo? So you should remember there is a transmembrane protein. So this GP1 linked protein, which is the one that is having the problem in PNH. So this GP1 linked protein is the one which is preventing the RBCs from undergoing complement mediated lysis. That's the point you need to remember. And as Unbation rightly says, you should remember CD55, which is the one which controls C3 and C5 convertases. It controls the early complement activation, and CD55 inhibits C3 and C5 convertases. Then CD59 is also very important, that is protecting the RBC from the complement. So PNH is the complement mediated hemolysis is what you need to remember. So what are all the consequences of the PNH, doctor? Please don't forget. Thrombosis, there is a renal failure, pulmonary hypertension, abdominal pain, shortness of breath. These are all the things which are the ones which affect the survival in the long run in case of the PNH. Now, doctor, let's go to the next favorite question of the NEET PG examiner. Glanzmann's thrombasthenia is because of defect in which receptor? So all platelet functional disorders, you have to be very sure for the tomorrow's exam, doc. So this is one important thing you should know. If you look at the endothelium, in the endothelium, you have the von Willebrand factor, right? Von Willebrand factor. ये प्लेटलेट है, ये भी एक प्लेटलेट है, ये दोनों को बाइंड करने वाला चीज है फिब्रिनोजन. And here you have a receptor, GP1B is the receptor. So GP1B rahe to two platelets can bind using the fibrinogen. Then this platelet binds to the vascular endothelium with the help of the von Willebrand factor. For that, on the side of the platelet, there is this GP1B, 1B. So then on the platelet, typically you are having a GP2B3A complex. That is another important thing that you require. So GP2B3A is the one which is making one platelet bind with another platelet using the fibrinogen. Then the GP1B is the one which is making platelet to bind with the help of the von Willebrand factor to the endothelium. So quickly you should remember, Glanzmann hota hai GP2B3A defect. GP1B receptor defect is Bernard-Solia, and von Willebrand factor deficiency is called the von Willebrand disease, as all of you know very well. So how are you going to remember this in the tomorrow's exam? Mainly, very easy to remember. Very easy to remember. You should develop some easy ways to remember. Ultimately, exam में 1B, B होता है Bernard-Solia. Bernard-Solia. Already von Willebrand factor is von Willebrand disease. What is left over? 2b 3a is the one which is left over. 2b 3a is the only one left over. And that is the one which is Glanzmann's thrombasthenia is what you have to ultimately remember. Now, doc. This is one important table. Once more, entrance में पूछेगा. You have to be very sure. Which you have to master. I want to make you to remember this. Whenever platelets are forming a clot, तीन चीजें होते. एक है एडेशन. पहला वो जाके वास्कुलर एंडोथेलियम को एडर होना है. बाद में एग्रीगेशन. एक प्लेटलेट दूसरे प्लेटलेट से फिब्रिनोजन के साथ it should combine. Later comes the activation. So, if you look at the various receptors, 1A, 2A and 1B, where are they useful? They are useful mainly for adhesion. 2B, 3A जो होता है, that is helping aggregation. एक प्लेटलेट दूसरे प्लेटलेट को फिब्रिनोजन के साथ मिलके बाइंड होने के लिए. ग्लैंजमैन्स थ्रोम्बस्थेनिया में एग्रीगेशन में दिक्कत है. Then 3B is the one which is there is no condition for that, so forget about 3B. Now, doctor, the binding target for the 1B is von Willebrand factor, and 1B deficient hai to what do you get? Bernard-Solia. 2B, 3A fibrinogen is the binding factor, and Glanzmann's thrombasthenia is the disorder. That is what you have to be emphatically sure about. Then once more, platelet dysfunction disorders present with a different bleeding pattern, and clotting factor disorders present with different bleeding pattern. You have to be very sure differences between the two. ये जो Glanzmann's thrombasthenia है प्लेटलेट का, so epistaxis, oral cavity bleeding, bruising, purpura, ecchymosis, menorrhagia, they are the presenting features of Glanzmann's thrombasthenia. So that is the reason always remember, if a female presents with menorrhagia, females don't show up in hemophilia. Unlikely to find a female hemophilic because it's X-linked. Whenever examiner's question starts with female presenting with bleeding, you should think of von Willebrand disease or Glanzmann, etc., etc. Male more likely to be hemophilia, but male can even be the subject of autosomal conditions. So that is a point you need to appreciate. So oral cavity bleeding, cutaneous bleeding, muscle bleeding, hematoma, joint bleeding, these are all the things that you see in case of the hemophilia. Right, doc? Now, next question. Zellweger's syndrome is which part of cell organelle? See, doc, every day we had been discussing last 15 years NEET PG NEET PG, NEET MDS वालों का biochemistry question 600 questions discuss कर रहे हैं. वहां भी Zellweger पूछेगा, MD entrance में भी Zellweger पूछेगा, right? So that is the reason you need to understand that NAT board is a common board. So when अब्बा कॉमन होता है, सारे बच्चों का क्या रहता, एक का शक्ल एक के जैसे दिखता है ना जी. हाँ, तो वैसा ही dad is same, that is NAT board. So that is the reason question banks are very similar. So always मैं हर एक बार आपको एक ही चीज जान से बोल रहा हूं. I mean you need to give a importance, doctor. You have 5 important question banks. एम्स ओरिजिनल वर्क चलता है यहाँ. किसी से कॉपी नहीं करते, अपने आप का क्वेश्चन पेपर तैयार होता. PGI, very original question bank. Then DNB, last 15 years का. Then All India come NEET PG का last 15 years का. Then JIPMER. This is the Bible, doctor. इन सारे चीजों से ईच लास्ट 15 years लिए तो 6,000 क्वेश्चंस रहता. सबको मिलाए तो 30,000 क्वेश्चंस रहता. ओरिजिनल क्वेश्चंस अगर आप लिए तो 20,000 क्वेश्चंस रहता. 20,000. ये 20,000 क्वेश्चंस को अगर आप रिवीजन कर सके तो हमारे साथ डॉक्टर मुरली भरद्वाज के साथ खत्म. Nobody will stop you, doctor, because 70% of the question paper is कुछ मेहनत करना पढ़ाई से होता है. 30% is elimination and common sense. But this 70%, you should be good. Then only your common sense and elimination capability will improve. So this 70% of the paper invariably comes from this 20,000 question bank. इसको revision करो, right? So on the onlinembbs.com, we have created the video library, 600 hours video library. Top NEET PG in 120 days. हर एक दिन का प्रोग्राम है. All 19 subjects are being arranged. 950 topics are discussed from the last 15 years of question bank. हर एक वीडियो के साथ PPT है, right? So गर्मा गर्म रिविजन करना. और एवरीडे हम अवेलेबल हैं आपके साथ, आपको इंस्पायर करने के लिए, पढ़ने के लिए, राइट? सो एवरी संडे ग्रैंड टेस्ट लेना, एवरीडे 20 MCQ का क्विज लेना, इमेज बेस्ड क्विज, राइट? एंड even in the onlinembbs.com, every day there is a 100 MCQ quiz. I mean the online test, discussion, assessment. So if you give 120 days of your time to me, 5 hours there, 2 hours with me in the evening, I am sure to make you the toppers. But 4 months of your time, come like super 30. हम भी एक super 1000 बनाएंगे, उसके लिए कोशिश कर रहे हैं. Super 1000, top 1000 ranks में our free evening class students should be in the top 1000 ranks. That is the day of a great honor. So doc, you're all going to promise me that you're going to make that dream come true. So doctor, paroxysm is the one where Zellweger syndrome is the one which is associated. So Zellweger mein the main problem is very long chain fatty acids. They won't be, they don't undergo oxidation. So that is the whole problem in these people. So when Zellweger happens, paroxysmal defect, typically you have this kind of a dysmorphic feature, upslanting eyes, high forehead, skin folds along the person's nasal border between the upper and lower eyelids, loss of muscle tone. They're all the classical features. Now doc, the most differentiating histological feature between ulcerative colitis and the Crohn's disease is the favorite question of the examiner. It is a diffuse pseudo polyp. So आपको cobblestoning में क्या दिखता है in Crohn's disease? In Crohn's disease. So typically in the Crohn's disease, cobblestoning is a feature of Crohn's disease. Whereas pseudopolyps, that is the feature characteristic of ulcerative colitis. These are the examples of how the pseudopolyps typically look like. Now doctor, जब भी हम inflammatory bowel disease के बारे में चर्चा करेंगे, invariably we have to visit this table. We have to do a revision of this table. हमारे 200 pages notebook में a table रहना है. That is the deal, right, doc? Now let's quickly run through this table, doctor. I know that all of you already know this table. Many times we discussed, but और एक बार, granularity of mucosa, classical of ulcerative colitis, collar button ulcers, ulcerative colitis, stippling of the mucosa, ulcerative colitis, thickening and loss of hostrations, the folds is the classical feature, pseudopolyps, ulcerative colitis, confluent, contiguous, circumferential disease, that is ulcerative colitis. Lumen get narrowed, loss of rectal valves, presacral space become widened. So you should remember that you have the anal canal and there is the rectum and sacrum. So there is something called presacral space. The presacral space become increased in the case of the ulcerative colitis. That is what you have to remember. Now, backwash ileitis is the classical name given for the colitis, ulcerative colitis. So, it's very important to remember that when we talk about I'm slowly getting habituated to using this board, right? So at the end, you have to give me a feedback. Our regular pattern of class that we conduct is better, or this is better. You have to give me a judgment at the end of the class. Accordingly, I will continue. Now, doc, we should remember that this is the small intestine. Small intestine typically become the colon, right? So if you take ulcerative colitis, it is involving inflammation of this entire colon. But it is the ileocecal valve at the junction of the small intestine and the colon is the stopping factor. But sometimes this can spill into it. And that is the reason backwash ileitis. Backwash ileitis is the classical feature in ulcerative colitis, which is there in the colon. Then another thing about Crohn's. Crohn's disease, agar aap dekhe to, it is not just restricted to colon. It is having skipped lesions. Another way to remember, जो skip करता है वो बहुत दूर चल सकता है. That is the reason all the way from anus to the mouth. Anus to the mouth. Typically, the Crohn's spreads is what you have to remember. Now let us talk quickly important things about Crohn's. You have aphthous ulcers, cobblestone appearance, segmental distribution, pseudopolyps, fissures, fistulae, sacculation strictures. Fissures, fistulae, sacculation strictures, transmural involvement. That is the Crohn's disease, is what you need to remember. G6PD deficiency. What type of inheritance, doctor? So you should remember it is X-linked recessive. X-linked recessive disorder. Now, which is an important positive marker of the follicular carcinoma. So it is a BCL2. Now, 2-3 comments about follicular carcinoma. So you should remember that the follicular carcinoma has B cell lineage and pan B cell markers are the ones which are expressed. And they also express germinal center associated markers CD10 BCL6. CD10 BCL6. Please don't forget. कभी कभी ऐसे चीजों को लिखना पड़ेगा. So yeah. So you should remember BCL6 and CD10. They are the two things that you need to remember when it comes to the follicular lymphoma. Now, BCL2 in fact is there in 80 to 90% of follicular lymphomas is what you should understand. Now, if you look at the Multi-drug resistant protein 2 is related to which disorder was the examiner's question. Typically, you see it in Dubin-Johnson syndrome, multi-drug resistant protein 2. Malignant hypertension may, which type of necrosis do you see? We see fibrinoid necrosis. So, this fibrinoid necrosis, है ना doctor? This is a potential image-based question that you are going to come across. So, be very sure to recognize it. So, fibrinoid necrosis is the one which is seen in case of malignant hypertension. Now, this is an interesting question, doc. You have been given a agglutination reaction. Based on this agglutination reaction, what is the type of the blood group is the question. So, doctor, you should remember when typically if he's a AB guy, AB blood group guy, then you get an appearance like this, both anti-A and anti-B. Whereas type B contains agglutinogen B. That is the reason on the anti-B side you get this appearance. Type A contains agglutinogen A. That's the reason on the anti-A side you get this. Type O contains no agglutinogens. That is the reason there is no agglutination at all. So this is how you should basically recognize. Now, if you look at the labeled one, the guy who is labeled 1, anti-A, no agglutination, anti-B, no agglutination, only anti-D, there is agglutination. So that is the reason his blood group is O positive, is what you should remember. So, if you are looking for blood group determination, this is a very important thing that you need to know, that A remain same as earlier. B is showing, for example, agglutination. D is showing agglutination. That's the reason it is positive, RH positive, then B positive, but A is not there. So it is B positive. So this is how you should recognize. So AB positive में कैसे दिखता? A is agglutination, B is agglutination, D is agglutination. AB negative, A agglutination, B agglutination, but D no agglutination. So this is what you have to emphatically remember. With regard to the MCH2, what is an incorrect statement? So you should remember that the MCH, the antigens are presented by, MHC2 antigens. They are derived from the extracellular proteins. They are encoded by HLA. To initiate immune response, you require the MCH2, and they are found on the antigen presenting cells. That's what you should remember. Now comes a very, very important table that should go directly here and into your 200 pages notebook doc. So, MHC class 1, MHC class 2, differences kya hai? So, most of the cells, they have MHC class 1. Only on antigen presenting cells kaun rehta hai? MHC class 2 is what you should remember. And class 1, they bind to the endogenous proteins which are synthesized inside a cell. Whereas class 2, exogenous. Class 2, exogenous. How will you remember? 1 means self. Self means Atma. Atma means Andar. Andar means endo. Some stupid way to remember. 2 is exo. Then cytotoxic T cells के ऊपर you have MHC class 1, helper T cells के ऊपर you have MHC class 2. CD8 class 1, CD4 class 2, and presence of foreign antigens, it induces the antibody production in case of the MHC class 2, and any overabundant antigens, then class 1 is also involved in the autoimmunity when there is a overabundant self antigens. That's the point you need to appreciate. Now, doc, and few more things. If you look molecular level, MHC class 1 has no invariant chain, constant chain, whereas MHC class 2 has a invariant chain. And MHC class 1 को 1 क्यों बोलते बोले तो 1 peptide which is being encoded by the HLA locus and beta 2 microglobulin, whereas 2 peptides encoded by HLA locus is the feature of MHC class 2 is what you need to remember. Now, what is the advantage of the CPD over that of the ACD in case of the blood storage is the examiner's question. The advantage of CPD mainly is there's a less fall of 2,3 dpg in case of the CPD. Now, let us look into the differences between ACD, CPD. By ACD क्या होता है? ACD होता है acid citrate dextrose. CPD है citrate phosphate dextrose. ACD में you have citric acid, sodium citrate and dextrose. And the shelf life is for about 21 days in case of the ACD. And the acid pH of the ACD, it's not much use to maintain the 2,3 dpg levels. Whereas the CPD, citrate, phosphate, dextrose, इसका alkaline pH है. That's the reason it is very helpful in maintaining the 2,3 dpg. And shelf life, that's the reason for the CPD, is 28 days. Whereas in the case of the ACD, it is only 21 days. That is the fundamental difference which you have to basically appreciate. Now, doc, which is the interleukin which is activated by the caspase 1 is a very important question. Interleukin 1, right? Interleukin 1, caspase 1. So, doctor, pura apoptosis, you have to be 100% sure. देखिए, अभी तक 2 क्वेश्चंस आए हैं एक ही टॉपिक में, एपोटोसिस में, नीट पीजी एग्जामिनर का क्वेश्चन बैंक नीट पीजी एग्जामिनर्स के आत्मा के अंदर, these are the 2 topics which are very dear to his heart. इसलिए वो नीट पीजी 2020, 21, 22, 23 और इवन 2050 नेक्स्ट हो नीट पीजी हो, एपोटोसिस के बिना पेपर नहीं रहता. That is what you have to basically remember. So, doc, you are going to promise me after this session is over, you are going to go back to the onlinembbs.com, and then in the video library, you are going to do the revision of apoptosis in pathology, one of the favorite area. Now, doc, which is true about alpha-1 antitrypsin? Alpha-1 antitrypsin inhibits the elastase in the lung. अगर alpha-1 antitrypsin नहीं है तो elastase in the lung become very dominant and active, and it starts destroying the lung parenchyma, and that is how you get the emphysema is what you need to remember. So, doc, typically alpha-1 antitrypsin, it is synthesized in the liver and catabolism in the liver, and typically there is a proteinase inhibitor. It is a proteinase inhibitor, and it is the inhibitor of the leukocytes and elastase. That is what you need to appreciate. Vitamin A, where is it stored? In which cells? It is stored in the ito cells. अच्छा भाई, ये ito क्या होता है? So you have a hepatocyte, and there is an endothelial cell, there is a Kupffer cell, there is a sinusoidal lumen, and there is a stellate cell, and this is called space of Dicey. Where is it located? It is between the sinusoidal lumen and the hepatocytes. यहाँ stellate cell रहता है, space of Dicey के अंदर stellate cell रहता है. And you need to remember that the main function of the stellate cells, इसी को itocell भी बोलते हैं, itocell, is mainly to store the vitamin A, is what you need to appreciate. Now, there's a lytic lesion in the skull, and there is a histology which is being given. So this is the classical appearance of what is this? Langerhans cell histiocytosis. Now, with regard to the mitochondrial inheritance, what is the true statement? Mitochondria are a part of cytosol. Whenever fertilization occurs, it is the mother's egg, the oocyte, which contributes to cytosol. That's the reason all mitochondrial inheritances are all the maternally inherited conditions is what you need to appreciate. Now, in case of infection with a polysaccharide capsule, what is that IgG subtype which is involved? Oh my God. There are subtypes in IgG, you have to be doubly sure. It is the IgG2 is what you need to remember. So, one quick understanding about this story. You have IgG2 antibodies which are against polysaccharide coating of certain capsulated organisms like Streptococcus pneumoniae, Haemophilus influenzae, etc. etc. Then IgG1 and IgG3 subclasses, they are against the proteins such as toxins. Who produce toxins? Tetanus produce toxins, diphtheria produce toxins. So against them you have IgG1 and IgG3 is what you have to understand. Rubella belongs to which subtype of virus? मालूम है तो बोलो, नहीं है तो जाओ. That's what examiner will tell in the tomorrow's exam. So be very sure, don't be disheartened by such single liners. They are like bullets on the temple, which you have to be very, very much sure and get ready with. So Togaviridae. So you should remember that Togaviridae is having alpha virus and ruby virus. So rubella belongs to the ruby virus, which belongs to the family of Togaviridae. A 5-year-old presented with painful red blister-like lesions on the tongue, gums, inside the cheeks. There's a red rash without itching. And what is the virus leading to it? Hand be involved hua, mouth be involved hua. What is that condition, doctor? Hand, foot, mouth, Coxsackie virus. No, doc. Legionella growth. What is the culture media? BCYE agar. अच्छा भाई BCYE agar क्या होता है? Buffered charcoal yeast extract agar is what you need to remember. And for growing the Legionella pneumophila, we use BCYE. So if you look at the growth of the Legionella colonies on the BCYE agar, they look like a small white colonies. They are fluorescent under the ultraviolet light. That's how the BCYE agar is what you need to remember. Infection with which organism lead to conjunctival hyperemia? Typically, leptospirosis. What is the full name of it? Leptospira icterohemorrhagica is what you need to remember. With the ingestion of cysticercus cellulose, what is the infection you get? Neurocysticercosis. छोटा बच्चा भी आंसर कर सकता है. So that is the reason, remember doctor, 300 MCQs of the examiner, 30-40 questions, दूध पीने बच्चे भी आंसर कर सकते, राइट? इतना सिंपल होता है. 20-30 क्वेश्चंस, तो कुछ भी पियो, दारू पियो, विस्की पियो, ब्रांडी पियो, समझ में नहीं आएगा. पढ़ो, जितना भी पढ़ो समझ में नहीं आएगा. 20 questions will be like that. भगवान तिरुपति बालाजी को छोड़ देना. Remaining 270 questions है ना डॉक्टर. I want all of you to cross the 250 line. 1000 plus score. That should be the only dream. आंख बंद करे तो वही याद आना है. हम बन रहे हैं MD, MS. That is the only dream that should be there for the next 6 months. So, doctor, this is the typical cystic sarcosis. You should know what is the life story of it. Now, doc, which is the test which does not use any labeled antibody? Is a very, very interesting question. Typically, in Wassermann's reaction, ELISA, hemagglutination, radioimmunoassay, in all these things we use the labeled antibody, not in hemagglutination. Hemagglutination assay में क्या होता है? You have a hemagglutinating virus. These are the RBCs. It leads to hemagglutination, and this is the appearance in the microtiter valve. If you have a hemagglutinating virus, there is an antibody to virus, antibody-antigen complexes form. So typically, this is the appearance on the microtiter valve, and there is no hemagglutination. So this is not using any radio label thing. That's what examiner is trying to ask you. Now, doc, which test do you use for an evaluation of the UTI screening? So you should remember that the leukocyte esterase test, all of us know, UTI के लिए इस्तेमाल करते. Nitrite test, blood test, they're all the ones which are done for UTI screening, not bedside culture. So nitrite test, leukocyte esterase test, blood test, they're all the ones, their respective sensitivities of all, which is considered to be very, very sensitive screening test, doctor. You should remember that it is the nitrite and or blood. It is 68, but nitrite, blood test and or leukocyte esterase, agar combine kare to sensitivity is highest. So this is the typical leukocyte esterase, doctor. It's a very rapid screening test. Leukocyte esterase is a very rapid screening test for detecting the pyuria, and it's a good screening test. Now, with regard to the needle stick injury, what is your story about it? All sharp injuries, they do not require reporting, and injured site should be immediately washed. Good news is HIV virus cannot survive in the ambient temperature. भारत के पोल्यूशन और भारत के गर्मी में HIV सर्वाइव नहीं हो पाता. Then non-dominant hand is generally involved. Dominant hand काम करता है, non-dominant hand prick होता है. Very low transmission. It is not high rate of transmission. That's the point you need to remember. So let us look into what is the risk of seroconversion that you will be having whenever there is any sharp injury. You should remember the HBV, it is 6 to 30%, HCV, it is 2%, HIV 0.3%. 0.3%. That's the point you need to be confident next time there is any HIV stick injury. Ideally, it should not happen, right? Now, hyper IgE syndrome is associated with what? Recurrent cold abscesses are very common in hyper IgE. So originally, historically, there is something called Job syndrome. There are two girls who had severe dermatitis, fair skin, recurrent staphylococcal infections with a cold abscess, and that is how Jobs was discovered. Then Buckley's syndrome. There are recurrent cutaneous, pulmonary and joint abscesses. growth retardation, coarse faces, boys with elevated serum IgE levels and dysnophilia. That is called Buckley's syndrome, is what you need to ultimately remember. So, with regard to this hyper IgE syndrome, you should remember that this gene is important. STAT3 gene mutation is the one associated with hyper IgE, is what you should remember. So, cold abscesses and the job syndrome, you should not basically forget. Now, the dose of diphtheria antitoxin कितना देते हैं? 20,000 to 1 lakh international units, or 20,000 to 1 lakh international units is what you need to remember. So, doc, symptomatic diphtheritic pharyngitis 20,000 to 40,000. For mild cases, 40,000. Moderate cases, 80,000. Severe cases, 1,20,000 units is the dose of the antitoxin, is what you have to ultimately remember. A 28-year-old visited China, ate crayfish, developed cough, fever, malaise. Then what is the organism which is associated? Lung fluke, that is Paragonimus westermanii. You need to recognize how the egg of it looks like. So Paragonimus eggs are identified in the sputum. So they are cuffed up typically. So the egg form is the one that leaves the definitive host and hatches into the miracidium, and that penetrates the snail. So snail is also involved in the transmission of Paragonimus. A 36-year-old veterinarian, he developed a black eschar, and what is this condition is a very important question. Right. Bacillus anthrax is what you need to basically remember. Now, disc diffusion antibiotic susceptibility test का नाम क्या है? That's what the examiner is asking. Kirby-Boyer's test. आपका डीएम नेफ्रोलॉजी, डीएम कार्डियोलॉजी बनने के लिए और किर्बी बॉयर याद रखने के लिए कुछ भी संबंध नहीं है, फिर भी एग्जामिनर फिल्टर लगाएगा, फिल्टर लगा के आपका जांच करेगा before he gives you the seat. So that's the reason you have to get ready. No disappointment about this kind of questions. So doctor, the Kirby-Boyer agar disc diffusion method is the one which is used to identify the susceptibility antibiotic. अगर susceptible है तो वो antibiotic disc के आजू बाजू में growth नहीं होगा. अगर susceptible नहीं है तो resistant है तो वो disc के आजू बाजू में growth होगा. That is called Kirby-Boyer's method, is what you need to basically understand. So this is how ampicillin, neomycin, trimethoprim, bezitrexine सब लगा के उसके आजू बाजू में ग्रोथ हो रहा है या नहीं है देख के एंटीबायोटिक सेंसिटिविटी रिपोर्ट microbiologist deliver. A 30-year-old abdominal pain, rectal prolapse, which is the organism that predisposes. Trichuris, trichura is what you have to basically remember. So I want to see all of you answering, right? If you are proactively answering the questions, you feel that you are a part of the game, right? So after all, these are all the NEET PG questions. Actual examiner के मन में क्या है, दिल में क्या है, before he is testing you, you have to be 100% sure about. So doctor, this is one example of the rectal prolapse and the trichuris, trichura. This can be a very solid image-based question. Solid image-based question. So don't forget, every day, evening 6 to 8, Chai Pe Charcha with Dr. Murli Bharadwaj, we have 20 image-based questions. The whole idea is to, we'll try to practice 20 image-based questions. And every month around 500 questions, another 6 months, about 3000 image based questions will have a practice, right? So that makes you undefeatable in the tomorrow's exam. What are you? You're the part of Super 1000. That's what you need to ultimately remember. So, which is the poison that you will get rid of by using gastric lavage? Carbolic acid. So, this one point you need to remember, doctor, that if the patient presents early to the hospital, less than 6 months of age, impaired level of consciousness, and mercury poisoning, gastric lavage is the one which is preferred. We use a 36 French tube in adolescents, 20 to 24 French tube in the case of the children, right? Children especially, you have to be very careful. When does an average doctor start producing children, doctor? Have you ever imagined? MBBS के बाद नीट पीजी के बाद सीट आने के बाद प्रोफेसर को पहला सेटिस्फाई करना, बाद में प्रोक्रिएशन होता है. But the child, especially when they are their second year, third year, very vulnerable for putting anything into the mouth. That is the time you need to be very, very careful. Even to that time you will be doing DM, right? Or MCH. So that is the time you have to be very, very careful about, doctor. So what are the important contraindications for the gastric lavage is the favorite question of the examiner. So you should remember corrosive poisons, absolute contraindication, except carbolic acid. Carbolic acid may de sakte. Relative contraindications, convulsant poisoning, comatose patient, volatile poisoning, upper GIT disease, and a patient with a marked hypothermia, hemorrhagic diathesis. You are not going to forget, right? So in a drowsy patient or a unconscious patient, पहला endotracheal tube डालो, intubation करो, then you attempt gastric lavage is what you need to remember. So with this, we will take it a break, doctor. So thanks for a patient listening and also appreciating the today's session. Tomorrow once more at 6 o'clock, we will have a final review. Another 100 questions बाकी रह गया biochemistry review में. Last 15 years, NEET MDS and All India Dental Exam में biochemistry का question bank revision कर रहे हैं हम topic wise, which is also going to be helpful for your tomorrow's exam. And tell your all dental classmates also to keep joining in the evening chai pe charcha until we finish the dental question bank. There are about 6,000 questions in anat physio, biochem, micro, pharma, patho, medicine, surgery, which were used in the last 15 years of All India Dental Exam. We will try to review them. And please tell me, you are happy with this kind of a broadcast, or you want our traditional one where I need to travel all the way to the studio? Which one is better? This I feel is better because you have a bigger screen. That's what I'm thinking. Please let me know. So, yes. So thank you very much and see you all tomorrow.